Welcome to the High Efficiency Practice, hosted by Brenda Mana, a show focused on how leaders build efficient, scalable healthcare and wellness businesses. Today's guest is Joanne Andrews, founder of Ascendant Healthcare Partners, where she helps public health leaders and healthcare organizations translate community health priorities into economic clarity. With a background spanning enterprise healthcare, global corporate strategy, and public health, Joanne focuses on helping communities understand the real cost of action versus inaction. In this conversation, she shares her perspective on public health innovation, funding strategy, and why data-driven decision-making is becoming essential for building stronger, healthier communities.
Welcome, Joanne from Ascendant Healthcare Partners. Today, we'll be diving into innovation in medical practice, and I'm particularly excited to talk about return of investment and how you've helped hospitals and clinics justify their resources invested so that we make our communities healthier through public health programs. Let's start and get a little bit of background of you and why did you start Ascendant Healthcare Partners?
Thank you, Brenda. I'm really grateful. So my background, it spans enterprise healthcare as well as global corporate strategy that I gained when I lived in Europe. I moved on to public sector and into public health once I moved back to the state. And that's when I started Ascendant Healthcare Partners. Public health needs to be seen through several different lenses: economic, regulatory, and operational. We're focusing on cost to the community and the return on investment. That's our beginning.
What is a day in your life as a leader and what do you do? How's your day like?
Long. It's a combination of what I was talking about, public health and the impact, but people, companies, and organizations struggle to quantify and defend that impact of health in economic terms. And so we produce reports based off of that. The three main things is we focus on budget contraction that's actually occurring due to some of the changes in our current government, and then the political pressure that's also happening, and then the rising community need, because all of those are players in today's economy. This creates a dangerous equation for us and for the communities: more accountability, less funding, higher expectations. Leaders thrive when they can translate the community health priorities into economic consequences. And we work on trying to do that. We do work on the community health needs assessments, but over the years, we've transitioned in this past 18-month period to focusing more on the cost of community. The majority of our day is when we talk with different clients, understanding what their current health priorities are, then looking into the community through data and seeing what is actually affecting their community. Some of that is explained in their improvement plans, but a lot of communities haven't had the ability to update their community health needs assessments and improvement plans because funding, helping them justify what the community needs, is a large part of our job. And we do that by preparing those reports as well as helping them with their board presentations, whether it's to a board of directors or to county commissioners.
The amount of parties that are involved in this process of not only generating the report, but presenting it to the right authorities. What is the timeline really? Because I'm thinking budgets that go annually, this process might take even longer than that. And if you generate the report on time, how can you just guarantee that the outcome might be close to the expectation when you build the report, if it's not too confusing?
No, I actually understand exactly what you're saying, and it's all rooted in data. So there's nothing hairy-fairy about it. I guess a good way of saying it is all built on facts. It's built on the data that is at county level, state level, and national databases. We pull all of that. We also look at previous interviews, and if it's been time, we dig in deeply to find it ourselves. We do that through actually taking a breath and understanding that public health economic is better than anything that they've heard of. And that's the message that we really want to send: is the focus is, yes, community health, and yes, public health. Everybody has so much passion towards, but at the end of the day, it's about doing the ROI. And it may sound like I've gotten a little bit off topic, but that is that one line about how they're working from passion. Because a lot of people in public health go into there because they're led. They're very intelligent people. They work very hard and they've dealt with scrutiny from every direction for a long period of time. And they're still standing and they're still trying to serve the community as a true steward. What our role is in that is helping them and being compassionate with them, but also helping them to have the numbers and the economics that go behind it. When they stand with their passion, they also have the data and the facts that substantiate it. That's really the reasoning of why we do what we do. But then circling back around, it is also the preparation that we're doing.
I step back on the timeline because the original question was, what was your week like? And I can tell there's a ton of calling in serving the public from a health standpoint. It is also something that any economy needs to pay for. I understand both sides of the desk, in which if we're going to be using taxpayers' dollars for X initiative, we need to make sure that the right incentives are out there so we get the return of investment, even if it's with a health outcome, right? Complexities that you need to handle throughout the process of helping the stewards of public health and how inspired they are and how good a purpose that is. But everything has a price because taxpayer dollars are going into buckets of initiatives and you're the magician putting data into context. That must take like 1 trillion hours a week.
It is. But with some technology, like some of it can be done a little bit quicker than what it used to could be done, but it still takes time, to say the least. We're not just looking at converting a single number or looking for that. It's about storytelling and it's about building a narrative around it. It becomes part of the community, if that makes sense. It's not just, oh, this is this. It's whenever you look at a community, you start, for simplicity, you start at the county level, then you look at the zip code level, and then you get down to the census tract level. And then you see where the issues are and how they change. You can also see quite quickly about a good example would be something like food desert. You can see which group is affected. If they're white, if they're African American, if they're Spanish, you can see the age, you can see all of this. So you can get quite specific for each one of them. It's about looking at the total picture, and a lot of communities can see the big picture, but what they can't see is down to that grassroots level and where their money is best spent and best targeted. If they have an amount of money, because everybody has, as I always tell my children, and I'm sure you'll do the same as you're older, there's one bucket of money. It's important that it's allocated for the different reasons and the different health priorities on top of their basic services that they also have to produce. But it helps us hone in on who needs what the most. And so that's really what it's doing, but it's also providing a cost and turning it into dollars. Cost of action, this is how much it would predictably cost to do X. If you do nothing, it would be a cost of Y. That clarity of providing that level of economic clarity, the fiscal accountability, and then the community cost of inaction and a decision grade, we get the public health ROI, which is a return on investment. That helps them build the strategic funding defense and the leadership level. They can differentiate themselves and what needs to actually occur in that community quickly.
You mentioned the census tract. I'm not sure I understand what that means.
You can get down to a level. You have a zip code, and a zip code is broken down at a closer level that you can actually look at. It's not by street because you can't get very low level like that because that would be a HIPAA violation. So what you are looking at is a smaller group. So it might be a couple of blocks within a community that you're actually looking at. So that way you can see where they are.
Perfect. I see. Thank you. You mentioned things that are probably difficult to aggregate, but you try to make sense out of these groups of data by use of AI. And the kind of like the first thing that comes to mind is I'm pretty sure things with AI have been smoothing out. But there might be things that are probably challenging, like it helps and sometimes it doesn't. So what in your day at Ascendant Healthcare Partners is challenging at times, with or without use of AI, but just in the context of the space that you occupy?
I think that the most challenging thing, honestly, is it's talking with different communities and hearing how passionate they are and how much they want change. A lot of them haven't done the ROI or presented it in a numeric way, and it's helping them understand that. They're very passionate, and a lot of them have MPHs and doctorates, and they do it, but that's not the way that our country has typically looked at public health. It hasn't been looking on what works financially for them and putting a number to those. Because out of the years of doing community health needs assessment, there has never been the budget piece to the back of it, but you never see it published. It's not normally attached to your needs assessment. The Public Health Accreditation Board doesn't require it to be attached. The states don't require it to be attached. So it often isn't converted in that way for that reason. If something isn't required and you have a million things to do and you have less resources, you make choice. It's not being negative, but that's also why we're here, is to help them do that for them. So they can go and talk about it to the people that they need, whether it's grants, funding, or at their board level or commissioner level to get the funding that they need. We're just part of the conduit to get them there.
And what's the part that actually gets you more excited to work? This is why I founded the company. This is exactly what I wanted to do.
What I've always wanted to do, and I do mean always, because whenever I was a little girl, like literally I was 10, I wrote in my journal, one day I want to grow up and I want to go far away and I want to learn things and I want to be able to come back and make a difference. I want to see communities, people doing well and living well. And I want to help communities and the leaders within their communities achieve that for their community, because I think everybody deserves to live well and to do well. And it all starts with our health. It's the basis. It's whenever a community gets excited, their leaders get excited, and it's not something that they shall, but you can tell that change is happening. I love that. One of the communities, and I'll just say this, it's a very sad story, but there was a county and they had children. We were looking at the hospital data that was going in, and what we saw was that there was a lot of that had severe diabetes. And we were just like, that we looked, they were actually having blindness, and that it had gone on that far, and it started, the root cause of it was obesity, and it was a generational thing, but the resources were there, they just weren't direct. And we found that. I'm very sorry for the people that happened to, but for every one person that we can help that doesn't happen to going forward, that's why we're here.
That is very inspiring. So much we talk about data analytics, and the outcomes of data processing. And that's actually a great example of how much having someone look at the aggregated data at that cellular level of a given county, which might be a big county, but still it's molecular opposed to the entire nation. It's how you actually make it. Each of your responses segue my next question. Speaking of a trend, and also part of what you do is because you always wanted to make a difference. What changes do you see? Where are we going from a public health perspective?
I see public health changing a lot. And I think the way that we have historically known public health, it won't exist that way in the years to come. And it is about reallocating the money. And it's just basically, if people are recognizing that they are going to be required to do what we're offering now, and we're trying to make it easy for them, because whenever we came out with the reports, we priced it lower. So that way we could help the most amount of people that were trying to be early adapters to get ready for it. The bottom line is it's going to continue to change, and the need for services are going to get greater, and the funding isn't necessarily going to be there. And so these hard decisions will have to be made. And that's the difficult part. And that's the biggest change I really see. Some of the data resources, they're changing. It's the ability to look back on historic data. Yes, we have some sets that go back over time and they look absolutely the same, but there's some that once you shift a variable or two, it doesn't become absolutely meaningful if you go back over time, if that makes sense. It's important that we're looking at consistency, the right numbers, the right story to basically ensure that the accuracy of what's being provided. What it means for public health is that the bottom line is they're changing and the communities are changing, and there's such a need or a wanting to get together and to act collectively. People have been separated after going back to COVID, and people are still doing more remote roles still, and even at the organizational level, and it's getting in and working together in those collective impact and those partnership and bonding in those and trying to find ways that communities and organizations can bond together. And instead of duplicating services, work together on the front end of streamlining them and owning the respective parts to collaborate to make a greater impact in that way.
You mentioned budget cuts, and I don't think if this is pre or post-COVID or didn't really change, but got more scrutiny.
How I see things is things are reallocated all the time. It's just when one door closes, another door opens. You just have to know which door it is. And public health is no different. So if one door is closing, like with COVID, there was a lot of funding that was given for the vaccines and for following up on those and looking into going and actually locating where the people were. And there was a lot of connect that happened during that with various organizations and the awareness that actually happened. That happened. And after that, people really got isolated during that time. And so when it was time to come back out, what we found is that a lot of people were affected with mental health. The nation and the world have not come back out in the same way as pre-COVID. They are not interacting the same way. If you go back to some public health data, what you'll find is community and having that sense of togetherness at being with your friends, going to church, different associations, those actually affect the outcomes of your health. It's the isolation also isn't as good on mental health. It's looking at it that way. There was a point where it got reallocated some to mental health, and then it's gotten moved around again for other things now. It's just changing all of the time, but it always has. It's cyclical.
And in cycle that changes, which is like the variables that you work with, what are the KPIs that you're most focused
For which aspect?
in terms of allocation of resources for the right initiatives? I know return of investment, of course, but is there any other KPIs or another one that it's associated but not necessarily exactly the same as the return of investment?
The reason why I keep on coming back to return on investment is because it is basically understanding the cost. For example, the cost of a nurse or a cost of disease or the cost of it growing within the community. There are a lot of effects that go to it. And it's like using obesity as a very basic outcome. It is a lot of our nation is obese. If you take obesity, then you look at different things that would probably come out of that. Type 2 diabetes, heart disease. And then with that also goes some form of usually mental health because they don't feel as good. And it's not saying everybody that's obese that these things happen to, but the probability becomes higher. It's understanding root causes of the different pieces that helps you understand that.
Thank you. That's actually the key. It might not be a numeric thing, but if you understand where everything starts, that's what you're aiming to propose a solution, or actually it's part of the ROI because it reduces the cost if you tackle it earlier. Agree. What are the challenges that you want to tackle? What's the expansion, the growth, the projects that you will accomplish?
Where I'd really like to be in 6 to 12 months from now, it's that people understand in organizations and counties, they understand that like the cost of community, it's inevitable. It's not optional. I think the quicker it's understood, I think the stronger that community will be. I hope that during this season of change that we get to play some role in actually helping communities communities understand the value of what this is, because it's new to a lot of people. And usually when clients are coming to us to start off with, it's, oh, they're thinking about regionalizing our health department and that we're not going to be at the county level anymore. They come and they think that there's just, oh, we'll give you this report and you're going to put it in at the 12th hour and it's all going to work. These are preparation documents. You don't wait until they've already made decisions like that. And so it's proactive, not react. I'm hoping that in what we are communicating and the reach outs and the education that we're doing, that they start to understand that. So it's not the 12th hour for them, and that they can basically, it's really to reframe that. My goal is to shift how public health leaders think about funding and influence and strategy so they can make better decisions. And that's basically it.
Very good. And would you say that the advocacy efforts for all these counties and communities or county level public health offices, if they don't, let's say they waited to the 12th hour, is this something that they can start shaping from the next one? Is this a, I don't know, a window that closes for 5 years, or is it something that is revisited on every whatever time of months?
So what I would say is over the next year, what I would want to be seeing and what I hope to be seeing, and I mean that in the English way, which means I really want that for them, is counties using economic data in funding hearings. Whenever they start to have those discussions, they're having it using numbers. And it's not just X people in our community have Y, it is the actual economic data. Then health officers speaking in fiscal language, money, basically the ROI, really talking about that. And then communities understanding the true cost of underinvestment. It's a cultural shift, but that's where it needs to go. The sooner they on board with that concept, I think that in the end, I really want the cost of community to become a national standard for financial clarity and public health, because that helps communities, counties, regions, state allocate appropriately. And the right people are getting served. It's not about those who have less, have more. It's not about that. And because I've heard a lot of people talk about that. What it does do is if you understand where issues are, you have a chance, you have an opportunity to act proactively to make changes before there is a crisis. Because if there are things that you can see from the outset, you can move quicker. And that's information that every community needs. So they're not lagging behind when accidents and diseases break out. It's more of an opportunity to act in like a preparedness plan of having even that data consolidated within that. And it helps even when natural disasters happen, because you already know which areas might be lower lying. We can physically see things like that, but then we also know ones that might need more aid than others in taking care of them.
Thank you. Last question, and then we would move to final remarks. The time in the podcast in which I give you the magic wand and then you fix something that's not working for you right now at Ascendant Healthcare Partners. What would that be? If you can fix something that's not working to fast forward you to month 12.
I would go back to what I said earlier. I would really like it if it was more clients were calling us before they got to where the decision had already been made. I wish that they had the tools we provide so they could have it as an ongoing narrative so they could make a difference and they could potentially change an outcome for a community.
Communication process would, instead of being outbound reach, is more inbound, as people would know that there's such tools and they would feel the need to be enabled. So by the time they have to make the call for whatever budget or grant, they can do it. It translates completely. This has been great. I want to allow a few minutes for you to share any final remarks, comments, wisdom with everybody else that might be hearing this.
What I really want leaders to understand is this: the pressure that they are feeling isn't a personal failure, it's a system shift. And that's what's actually happening. Accountability is rising, budgets are tightening, and community needs are not slowing down. The question really becomes, how do you protect your mission when the rules of funding have changed. The leaders who thrive in this specific era that we're in are the ones who can translate public health priorities into economic clarity. And what I mean by that is it's not just outcomes, it's also the consequences. Because when you can hear clearly the answer, what does inaction cost our community or the community, you move to the conversation from nice to have to a must fund. And that's really what I've been trying to share. It's changing that shift. The truth is every community already pays. They do and they have. They do it through preventable use, workforce loss, homelessness, unmanaged chronic diseases, and behavioral health crises. It's being spent regardless. But the difference is whether it's being spent strategically or reactively. So my takeaway that I would like them to leave with is stop defending public health with passion alone. Lead it with evidence, context, and economics. And pick your top 3 priorities that's in the community, quantify the cost of doing nothing, and then give decision makers something they can stand on at their budget time. That's how to protect the funding. And that's how we earn trust. They earn trust. And that's how public health becomes non-negotiable again. That's all I got.
It's amazing. Thank you so much.
Thank you for your time.